Hello, everyone. My name is Keonta Houston, and today I will be talking about a study that me and some of my colleagues did on patterns of pharmacologic and non pharmacologic treatment, treatment satisfaction, and perceived tolerability in patients with fibromyalgia. To give a little background information, fibromyalgia is a central sensitization syndrome characterized by widespread pain that is frequently accompanied by symptoms such as anxiety, depression, sleep disturbance, fatigue, and cognitive problems. Fibromyalgia does have a 2.7% as far as worldwide prevalence and is predominantly seen in more females than males. After osteoarthritis, it is the most frequent disorder seen in rheumatology clinics. Uh, it is generally agreed that the management of fibromyalgia requires a combination of non pharmacologic treatments as the initial approach, and then thereafter pharmacologic treatments. It has been reported that less than half of the patients with fibromyalgia are satisfied with the current medication that they are receiving. In addition, it also appears that an important proportion of patients with fibromyalgia do not receive appropriate treatment and that treatment adherence is very poor. The purpose of this study is to find the patterns of treatment among patients with fibromyalgia in Spain and to assess patient satisfaction and perceived tolerability of the treatment received. So the hypothesis that my colleagues and I came up with was patients with fibromyalgia in Spain are overtreated with a combination of non-pharmacologic and pharmacologic therapies. Several of these therapies lack adequate support from randomized clinical trials and or clinical practice guidelines. This overtreatment is not associated with relevant clinical benefits or patient satisfaction and, in the case of pharmacologic treatments, poses tolerability and safety issues. This was an observational cross-sectional study conducted in Spain between September of 2015 through March of 2017. Participation in the survey was solicited through several patient associations in every region of Spain and diffusion through social networks. Participants were briefly informed at the beginning of the survey of its objectives and that they should be aged 18 or older and have a diagnosis of fibromyalgia. Due to the nature of the survey, diagnosis relied on patients' reports and could not be confirmed by the study of the investigators. Participants were also informed that answering the survey was equivalent to consent to participate in the study and that their data would be used for investigational purposes. Since the questionnaire was anonymous, no written informed consent was required. So the survey consisted of 5 blocks of treatment. These included socio-demographic information, clinical data, data on pharmacologic treatments, data on non-pharmacologic treatments, and an assessment of patient satisfaction with the treatment overall. Socio-demographic treatment included things such as age, sex, marital status, education level, and employment status. Clinical data comprised information on duration of diagnosis, comorbidities, and 5 questions used on the 10-point numerical rating scale, which I will be referring to as the NRS, to evaluate the impact of the disease on daily life, pain intensity, sleep quality, etc. Pharmacologic treatment included things such as medications and doses of the medication that they're currently receiving, whether the patient is taking vitamins, etc. Non pharmacologic treatment included information on physical exercise, psychotherapy, both being measured by type and frequency, and an open question for these treatments. Now, patient satisfaction with treatment was evaluated with a 10-point NRS, where 1 was indicating lack of satisfaction and 10 indicating that the patient was completely satisfied. There was 5 NRSs, 1 for each treatment. Below, I have included the link to the survey that the patients had to take. The statistical analysis were mostly descriptive, using means and standard deviation for quantitative variables and absolute and relative frequencies for qualitative variables. Difference in the mean satisfaction according to the number of drugs received was analyzed using a one-way analysis of variance, also referred to as ANOVA. Mean satisfaction of each non-pharmacologic treatment was compared with the mean satisfaction of pharmacologic treatment using an unpaired t-test. We did perform two exploratory multiple linear regression analyses. The first being treatment satisfaction as evaluated with the NRS, that was the dependent variable. And then some of the independent variables included age and years, sex, time of diagnosis, which was categorized for less than 1 year, 1 to 5 years, and greater than 1 year. As far as the second model, this was performed only in patients who were receiving pharmacologic treatment. The dependent variable was the score of the NRS of impact on daily life, and the independent variables were the same as the first model. As stated, all of those independent variables were not included, but some of them included things, like I said, such as age and years, sex, um, time of diagnoses, performing physical exercise, number of diseases associated with fibromyalgia, etc., etc. All comparisons were two-tailed and considered significant if the p-value was less than 0.05. So overall, 1,166 subjects responded to the questionnaire, and after removing duplicates with a number of 103 participants and questionnaires from countries other than Spain with a number of 148 participants, we had 915 evaluable questionnaires. Um, Subjects were predominantly middle-aged married women. Patients had an established diagnosis of fibromyalgia for more than 5 years and exhibited moderate to severe pain, sleep disturbance, and an impact on daily life. They also presented a high number of comorbidities, mainly with central sensitization entities and psychiatric disorders of musculoskeletal disorders. The most frequent non pharmacological treatment was physical exercise, being at 85%, and most commonly walking at 66%. A lot of these patients did physical exercise for more than 3 days out of the week, and 44% of patients was at 2 to 3 days per week. They did have a specified diet, which was hypocaloric and gluten-free diets. Um, a lot of them took supplements and many types of vitamins, and one third of the patients were receiving psychotherapy. However, a majority of the patients, being at 73%, received it less than 1 day out of the week. As far as pharmacological treatment, they received that was received by 87% of patients, and it was prescribed to half of the participants by a family physician, a rheumatologist, or even both. Let's note that regardless of treatment modality, satisfaction was still low, but it was significantly higher in any non-pharmacologic approach opposed to a pharmacologic treatment. With a score of 6.0 in the 10-point NRS, acupuncture and physiotherapy were the interventions associated with the highest satisfaction. The increase in the number of drugs prescribed for the treatment of fibromyalgia was not associated with satisfactorily significant increase in satisfaction. So basically, what we're saying is, even if there was an increase in the drug that was taken, that doesn't necessarily mean that the satisfaction would have increased for the participants. So results indicate that patients with fibromyalgia in Spain are usually treated with a combination of drugs and non-pharmacologic strategies. The same as our hypothesis, we concluded that satisfaction with most treatment approaches is poor, and the treatment that patients were receiving appears inadequate in a substantial proportion of patients. Now, our study did have several limitations that should be considered when interpreting the results. Um, the first one was we used a cross-sectional design, which, although adequate for evaluating prescription patterns, it is subjected to survival bias. Um, Another one is the cross-sectional design and lack of information on other important variables such as fatigue or cognition make that our multivariate analyses for factors associated with treatment satisfaction and with the impact of daily life can only be considered exploratory. And lastly, the diagnosis of fibromyalgia was self-reported, and due to the anonymous nature of the study, we could not confirm by a member of the research team this information. Finally, our survey was conducted in a single European country, thus contributing to the limitations of its representativeness. So overall, there is wide room for improvement in the management of these patients by all stakeholders involved. Some of those improvements in the future can be physicians improving the rational use of drugs and other interventions, and also providing a better patient education on their disease and therapeutic alternatives. As far as helping us that deal with research, the national health authorities and organizations providing funding for research favoring the inclusion of the search for the evaluation of new therapeutic, possibly multimodal alternatives for patients in the research agenda would help.